So, good evening to all of you. I am Shantanu Mukherjee, your host for the evening. On behalf of Torrent Pharma, I welcome you all to this special online CME program under Back to Basics programs. Today we have gathered to have discussion on arterial pulse. I welcome Dr. Sudhakar Rao, who is the chief organizer of this program. And for presentation and discussion on the topic, I welcome our esteemed speaker for the day. We have with us Professor Dr. Ranjan Shetty, intervention cardiologist and HOD of Manipal Hospital, Bangalore. I am sure this unique platform where evidence meets experience will help all to enrich their knowledge even during these COVID times. Being the host of this program, let me brief some important aspect of this program. All participants to please keep their mics muted except the panelists. This is to avoid background noise. If you have any question to ask, please use the chat option and send it to us, and we shall present this in front of the panel member for answering. You can send the question anytime during the presentation. So once again, I welcome you all and request our speaker, Professor Dr. Ranjan Shetty, to take the proceeding further. Dr. Shetty, please.
Hi, everybody, and thank you once again for joining this talk. So today we thought we'll talk about pulse, although you all realize it's an extremely basic topic, but very important. So we probably will not be doing the routine discussion because most of you are aware about pulse. Let's try to understand some concepts and understand some science if possible. So all of us know we have been checking pulse. Pulse is very important from Hindi movies to history. Everywhere the pulse is something which is very common. Now it comes from the Greek word, and actually Greeks did have a lot of information about pulse. Hippocrates himself actually picked up time it was benign. His own statement once was that if your VPC is once in a way, abnormality once in a way, it is fine. But according to him, if you had it more than 10 times hour, that was considered bad. So he did have some idea about cardiac arrhythmias and cardiac abnormality. Now what we should understand is, what is pulse? Is it the blood what you feel? All of us know how to feel it, but what is that what you feel? Do you feel the blood going through the vessel, or is it something else? So what we need to understand right away, that it's not the blood. Blood moves, it's a column, but what you feel as pulse is not the blood, but it is the pressure wave. It's the wave which transmits. So it starts at aorta, and there is like a Mexican wave, there is a pressure wave which starts, and that is the one which falls through the vessel wall and gets transmitted. So typically blood takes much longer time. If the blood is ejected from the heart, the rate of flow of blood is 0.5 meters per second. It's very slow, whereas the pulse wave or the pulse is actually 5 meters per second. That means the pulse actually flows 10 times faster than the wave. Also, one more thing which probably we should understand right away, since it's not the flow but the waveform of on the vessel which occurs, is that there are two components to that. I'll come to that little later. There is a forward component which comes because of ejection of the blood. Although it's not the blood which transmits, it is the ejection of the blood into aorta which makes the elastic aorta expand and recoil back. So this expansion and recoil back produces some sort of a pressure waves on the arterial wall which gets transmitted. But there is also one more component which is important even in our practice. There is a reversal of from the periphery. There is also it's a wave. How when the waves hit any object, whether it like a sea wave or something, when it hits something, the opposite structure also vibrates and sends the wave back. So pulse is a mixture of an antigrade wave, not flow, wave, which goes from aorta, and also a retrograde which comes from periphery. And the timing is so beautifully matched that the retrograde and antigrade, actually both of them fall on systole. So if things are fine, the antigrade and the retrograde both fall on systole, and that's why you get that waveform of the bulb. There are some physiological, pathological condition where the reflected wave actually doesn't fall on systole, it falls in diastole, and that will be explanation for some of the pulse. So once you understand this, most explanation for the pulse becomes easy. For example, why does the Hill sign occur at all? Why do you get a collapsing pulse? What why are we not that keen on beta blocker as antihypertensive? Partly because beta blockers actually disrupts this rhythm of pulse. It makes chronotropic, some sort of an incompetence, that the reflected wave then doesn't fall on systole but falls on diastole and produces, that may be the reason why they are not very effective antihypertensives. So if people have anybody has doubt, please put it in the chat box. So when I'll keep the chat box open, so if you're not following anything, please let me know, and we could discuss that. Okay, so this is the key component. So what we understood here is it's not the blood flowing but the pressure wave going. So there are two components, one from aorta going forward, one from all of the periphery getting summated and coming back, that also going at systole. So that's where we are when we are discussing about the pulse. Pulse contour is something which we should understand, and the factors affecting this also should be understood. I'm sure most of you are aware of the contour, where you think there is a dicrotic notch, there are waves before and waves after, but there is something else which we should think. I already discussed about this genesis of the pulse having two components. Now let's look at the pulse contour. Now, pulse contour varies. This depends on the way the pulse, which is not the blood flow, but the way, the way from when the arteries changes from elastic artery to a little less elastic or more muscular artery, the contour changes. The way the pressure is transmitted, it changes. So if you see here, this is how it looks in ascending aorta. Anybody who has done an angiogram, or you realize that the radial pulse contour is actually not same as the central pulse contour. There is a difference. There is the width become lesser as you go distally, the peak becomes more, and the dicrotic notch comes down. Now we should understand about dicrotic and anacrotic notch right away. So early systole, there are two waves in systole in pulse. That's something which you should understand. Once you understand this, the most of the explanation for most abnormality becomes very simple. So you have two waves. One is a percussion wave, one is a tidal wave. The percussion wave, which is that initial rapid wave, so if I have to understand it, it's more like the ejection of the blood itself which into the aorta, which produces that rapid expansion. That is the percussion wave. And that is, then there is an anacrotic notch. All of you know dicrotic notch, and most of you have heard this anacrotic notch, but understand this, there is anacrotic notch. It's very difficult to decipher. A simple pulse tracing may not show it. You may have to take it in a lower speed to really unearth and see this. So you have a percussion wave, you have a tidal wave, you have anacrotic notch between percussion and tidal, and you have dicrotic notch between the tidal and the diastolic waves. Okay, so that's what we should understand. So remember, there is anacrotic wave which is little before mid systole, and a dicrotic notch which is the mechanism of dicrotic notch is pretty simple. It is closure of aortic wall itself. So that becomes the beginning of diastole. So closure of the aortic wall is dicrotic. The vibration of that, since we know the pulse is vibration, so vibration of that gets carried even across the vessel and gives you a dicrotic notch. And also at this point, the flow, aorta is completely recovered and the pressure wave transmits into diastole. So this is what we need to understand. Okay, the anacrotic, actually, there's a question by Dr. Allen. The anacrotic notch, the explanation, there are multiple explanations, but one which I believe is the elastic recoil of aorta. The initial pressure which pushes the aorta, the recoil followed by further flow. That recoil is probably the reason for anacrotic notch. So that is the juncture of, so if you ask me, the initial anacrotic notch comes because of the blood in aorta pushing the aorta, then there is a slight recoil, then the peripheral waves, the tidal wave is predominantly determined by the pressure wave which comes back. The percussion wave is predominantly decided by the blood and the LV. The tidal wave is predominantly decided by the reflected wave. So the difference between that is anacrotic. But at end of systole, when the aortic wall actually closes, you get a diacrotic notch. So this is how it looks. It's sometimes difficult to pick anacrotic. So percussion wave, and then there is anacrotic notch, and then there is a tidal wave, then there is dicrotic notch. This you realize is with the phonocardiogram, but this is slightly stretched. When you actually see in when the aortic tracing, because the heart rate is higher, it looks narrow. So you may have to slightly stretch the pulse to actually see all these waves. But remember, if there is one carry home message today, it is about anacrotic notch, and that helps you to identify multiple this. Now there are differences between central pulses and peripheral pulses. The upstroke, if you are just looking at pulse, then you realize that the central is more rounded and more blunted. The waveform is different, whereas peripheral, the upstroke is steeper. Both have anacrotic in the ascending limb, but the dicrotic is actually way delayed in a peripheral pulse. The dicrotic notch comes really down, whereas in a central pulse, the dicrotic is also little in front. So this is how it looks. Anacrotic is almost same, it's rounded. When you look at femoral or radial, you find so much more augmentation of the pulse and the dicrotic coming down, partially because these waves are more close to periphery. So you tend to see more reflected effect. And as we discussed already, the reflected wave is more tidal wave than actually a percussion wave. Okay, percussion wave is more from aorta and the tidal wave is more from the periphery. So the reason is already written. It's the pressure wave which compounds. The change of vessel structure also affects the distensibility, changes the elastic nature, becomes more muscular, and also the caliber is less, and like current from the main line, when it goes to lot of peripheral sign, these are all peripheral transmission of the central pulse. So some waves tend to get depressed or suppressed. So now let's start with the important thing. When you go to exam, there are some things which are really must, and you need to tell about those things. I'm sure most of you are well aware of these conditions. So one is obviously rate, and there is tachycardia, bradycardia. The rhythm, we'll discuss little about rhythm, little about volume, little more about character, and we'll go to each of them. Now, the most important pulse actually is the radial pulse, and that is something because that's where you measure. How do you do it? Although, see, whenever I'm describing any method, remember there are more than one methods to do that, and different authors have given different methods. I'm not here to tell which is the correct one or which is the wrong one, but I could say this is the method I'm the one who is using it. But there will be proponent and opponent for many other methods. So be very flexible when you're describing pulse. People could have their own method. Be a little flexible. So radial, we all know 3 fingers are used. It's important that the middle finger is the one. See, people could ask you one more thing in exam for you is whatever method is actually people will ask you to demonstrate some sign. When you're giving exam, at least 2 or 3 signs are actually asked you to demonstrate, and we did discuss some of them in our previous discussion about apex palpation or palpation of different things, percussion for right heart boulder. Pulse is one of them. They could tell you examine carotid pulse, examine brachial pulse. You need to learn them, and you need to know, because any case the pulse can be asked. Make sure that you have sufficient knowledge when you are dealing with pulse. So when you use 3 fingers, the middle is the one which you tell rate and volume. the index finger. So when you keep like this, and the index finger is the one which actually is used, that's the distal finger. Now the distal finger is used to occlude or compress, and the proximal, the middle finger is one which is used to this. And it's also, as we keep discussing, it's a multi-step process. It's not just one step. You may have to vary the pressure to get different qualities and different this about pulse. I think this is something which we all know: tachycardia, bradycardia. So heart rate has to be explained, and whenever there is a disparity, like if you're dealing with AF or VPCs, you need to actually talk about the heart rate. Pulse rate is just one part. Wherever pulse rate and heart rate don't match, you should remember to describe heart rate. And if it is less than 60, your final diagnosis should actually have bradycardia, and if it is more than 100, the final diagnosis should also have tachycardia. This is something which people miss. They miss hypertension when it's part of the diagnosis, and when they miss heart rate. So if you find a heart rate which is higher, then you need to do that. Then regularity or the rhythm, this is something, again, I think most of you know very well. I think what is, you need to describe it well, whether it is irregular, irregular, or whether it is regularly irregular. That means irregularity comes at a frequent interval, like ventricular bigeminy or trigeminy. Bigeminy means alternate beat is abnormal. Trigeminy actually means the third beat is abnormal. And irregular occurs in atrial fibrillation, sometime some VTs, MATs, and I mean, most of you are familiar with ECG, so you do get the idea. Now, after rate and rhythm, next is volume. Now, what do you, now what is this volume, and what is the importance of the volume? Some things with pulse, that's what you should remember. There are some 3-4 pulses and volume. It has to be correlated with BP apparatus. This is one more standard question. There are some pulses which needs to be confirmed with BP apparatus, and we are going to discuss that in a short while. But remember, volume itself has to be correlated. There's no need to be very heroic. If you have doubt in volume, check the BP. Volume is nothing but the pulse pressure. So typically 30 to 60 is normal, 40 to 50 is what most people would have. Anything more than 6 is called large volume, and anything less than 30 is small volume. So always your examiner is going to compare volume with the final. There are very few exceptions where pulse looks large volume, it gives you that feeling, but then the pulse pressure is actually not much. So we'll come to that in a short while, but most of the time the volume, it's a good volume or a poor volume, should actually be correlated with BP apparatus. This is one thing, we are going to talk about 3-4 things where BP apparatus and pulse has to be correlated, and this is one of the things which depends. It also depends on arterial compliance, especially with the poor compliance. In older people, it looks more prominent and more bounding, or volume looks higher. But in their defense, most elderly do have a low diastolic BP, hence the volume actually is becomes higher. Now, if you want this is something which we are very used to, where your grading, typically pulse is 3+, especially if you're dealing with a peripheral vascular disease. It's very important for you to grade it. Most other cases, it's enough if you tell that all peripheral pulse is felt, and it is well felt and it's normally felt. When it's bounding, it becomes 4+. But let me tell you something here right away. Most of you in exam may not palpate a dorsalis pedis. That would be utterly wrong if you're not doing. Make a habit of making your patient lie down. If you are not able to find all pulse, make a habit. Spend a minute just after calculating pulse, because this is your first impression with your examiner. When you start your examination, your first impression actually comes from pulse. And imagine dorsalis pedis is missing, maybe physiological, maybe altered anatomy, and examiner. I've seen very senior examiners almost always look for dorsalis pedis. So you need to get radial checked, you need to get carotid checks, you also need to see the femoral and dorsalis pedis. Make sure you always palpate these pulses. They could be abnormal for whatever reason, but if there is a finding, you need to demonstrate. It looks very bad if you tell all peripheral pulses palpable. Examiner pinpoints that something is not there, and then you realize it's not there. It looks very, very bad. Now, what's the character of pulse? I think if I have to tell something about this class, the whole class is about this, because character is something which needs to be described about a pulse, because rate rhythm is MBBS, and most people, at your level definitely know. We should probably spend little more time in describing a character, and that is something which becomes difficult. It's not that easy. And where do we pick up character? Most characters are central. That's what you should understand. Again, books will vary on some of the explanation, especially when you are dealing with bispherates. But remember, the most of the time character is a central feature, because as we realize, the contour of the pulse changes peripherally. It becomes very difficult. But any alterance kind of things, pulses alterance, when strong, one weak, the peripheral becomes much better to pick up the character, not the central pulses. But if you want to look at, say, bisference, or if you want to look at a lot of other things, the central pulse, central is one which becomes which is important. Now, what's the normal character of the pulse? The pulse actually has an upstroke, which is corresponding to, just with S1, there is an upstroke which comes. Then there is incessura, or what we call as diacrotic notch, which corresponds to second art sound. Most of the time, the percussion wave is palpable, because it is, that is the only way, because from zero, that's what you get, and that's because of the blood in aorta now stretching the aorta and the pressure wave getting transmitted. So you almost always get the percussion wave. You don't typically feel the tidal wave when you feel. But when you look at the graph, most of the time what you see in a graph is more tidal than percussion wave. Okay, and the character of the pulse, as we discussed, invariably is described in carotid with very few exceptions. Now let's see some specific, simple pulses to start with. So you could have a weak pulse, which is small volume and narrow, which will be called hypokinetic pulse, and you could have exact opposite of it, which is hyperkinetic pulse, which could be found in any case where there is volume lead to LV, there is reflow, or it could also be found in hyperkinetic condition like thyrotoxicosis periphery. So weak pulse could occur in cardiac failure or a shock, any kind of shock, and if the shock is too severe, you could also have what we call as a dicrotic pulse. We'll come to that later, but right now just concentrate on the weak pulse, which is called hypokinetic pulse, or you could have a very strong rapid rising point, which is hyperkinetic. If you want to know about hyperkinetic, you could, that could condition in any condition where there is high output, including thyrotoxicosis, beriberi, Paget's disease, anemia, pregnancy, or if you run around and come, you'll still have a large volume hyperkinetic pulse. It's also found in MR and VSD. That's something which you should understand here. Both MR and VSD are volume overload of LV. So there's a huge volume in LV, and the LV contracts very forcefully. The blood jumps into aorta, and that force produces a huge percussion wave and a huge opening of the stretching of aorta. But then there is an abrupt closure, because the blood actually is not going into aorta, it's more going into LA or RV, like in MR-VSD. So you get a feeling of what is known as low collapsing pulse, or the amplitude of these are the exception, where the volume, when you feel the pulse, you feel there is too much volume, they just go up, but then there is a sudden fall. The pulse pressure is not very wide in MR and VSD, but the volume is very good. So they are also exception of hyperkinetic pulse. So you get hyperkinetic pulse in aortic backflows, like in AR, PDA, fistulas, and also RSOV. You get it in pure hyperkinetic condition like thyrotoxicosis, beriberi, pregnancy, pages. You also get it in MR and VSD where LV is hyperkinetic, but in this condition, these two, the pulse pressure is not wide. All other exception, whether it is a pure hyperkinetic or backflow of blood, the pulse pressure is also wide, but here the pulse pressure is not wide. Now let's go to something which we discussed today. What is an anacrotic pulse? So anacrotic pulse is where you can actually feel the anacrotic pulse very clearly. That's called an anacrotic pulse. That means you are able to feel, you can feel that the anacrotic notch is delayed. So this occurs, as I'm sure you must have guessed this occurs in severe aortic stenosis, but it's not same as parvus et tardus. See, parvus et tardus is a delayed pulse which is low volume. It's parvus means it's small. It is tardus means it is delayed. But an anacrotic pulse, if at all, is just a tardus pulse. It's not parvus et tardus. It's just tardus. That means cardiac output here is normal. The amount of blood coming is normal. So it's not a small pulse. It's a good volume pulse. Not hyper volume, but a good volume pulse with a systole which is delayed here. The one point I want to tell you is this is the one pulse which you may mistake for a whisperance, because the anacrotic wave is now delayed, and most of the time there is also thrill in carotid in these conditions. You could miss this for a whisperance pulse. So if you think the diagnosis is AS and there is a features like whisperance which you feel as whisperance, I'm very sure that's the anacrotic pulse. Okay, so it's to remember that. So you do not get in a severe AS, you do not get a whisperance pulse. Whisperance is feature of AR. We'll come to that. But if you get a whisperance like pulse and every other feature, if you're making severe AS, call it anacrotic pulse. So with a normal cardiac output, you can see the pulse delayed. It's a tardus pulse. Invariably there is a epico-carotid delay in this condition, and almost always there is a carotid stutter or carotid delay. But if you are careful enough, you will relay that the pulse is there, but it is little delayed. So this is what we discussed as anacrotic pulse. Difference between parvus et tardus, cardiac output is normal here. So you would see this is how it looks, and because of this multiple stutters, shudders which you see, you will confuse it for a whisperance. So do not confuse it for whisperance. This is anacrotic. Severe AS pulse like this is anacrotic. It's a slow rising, delayed, normal volume pulse. So I hope all of you understood this. Anybody wants any question, please put it in the chat. I will be happy to answer. So remember this. This is something which you must know. Otherwise, you'll make a mistake of calling it a whisperance pulse. So this is anacrotic pulse. Okay. Parvus et tardus, on the other hand, also occurs in severe AS, but typically the cardiac output is delayed. So it's a smaller pulse, okay, which is small, but at tardus. Typically, I don't think so you'll ever miss a parvus et tardus. You can feel it actually, but the anacrotic is one. So if you see, this is how the normal pulse looks in this example. And this is how a parvus et tardus pulse looks. This occurs in severe aortic stenosis. Typically, cardiac output is low. So anacrotic, I think there's a question from Dr. Katyayani. Anacrotic pulse is seen in severe AS, but with normal cardiac output. It's a tardus pulse. If you have to give one more name for anacrotic, it is tardus pulse. It's a delayed pulse with the stutter. I'm just going to show you this example. See, the heart sound is already started. Typically, you would have expected the pulse to be here, but it is here. So if you are looking at epico-carotid, there is also delay which occurs. I'll come to that delay again. But the problem is the shuddering. Shuddering makes you think that it is actually a whisperance. Okay, whereas parvus et tardus also occurs but in a severe AS, but it is small. Okay, now let's come to the other pulse, which is probably important, which is collapsing pulse or water hammer pulse. It's named after a Victorian toy, and all of you know about it. So in this case, we need to understand what is the pulse, why does it happen, and is it very specific for the condition we are looking at, or is it found in many conditions, and why should you do all that maneuvers. What is the necessity? Why is it not enough just to say that this is a high volume pulse? So the collapsing pulse, as you know, occurs, and it's a predominant, a big sign of okay. So there's one more question: mechanism of provenance of anacrotic pulse in AS. Yes, in AS, if the it's only AS. Why? Because what does anacrotic means? The anacrotic notch, which has to be in the ascending limb, now is shifted way away. That means there is a LVOT, there is some obstruction to left ventricular outflow, which is delaying. But it occurs if the cardiac output is normal. If the cardiac output is low, the pulse volume also comes down. So whenever there is a normal pulse volume, but the only problem is delayed, that means switching of anacrotic pulse away, that's called anacrotic pulse. So it's found only in severe AS, but with fair cardiac output. Okay. Now let's discuss about the AR pulse, or a collapsing water pulse. So here, why does it happen, and what is the mechanism? Okay. So why should you do this? So it was mainly found in the, that Victorian toy was supposed to hit. When you turn it around, it would come and hit you, and you would get that almost like a tapping or a slapping feature. So there are some things which we need to do. The collapsing pulse could occur in many conditions. It's not just aortic regurgitation. Any high volume pulse you get, but it's much more specific in an aortic runoff. When you say aortic runoff, it may be AR, it may be PDA, where the blood is going to aorta, it may be RSOV, it may also be fistulas, especially coronary AV fistula. You could also find it in cyanotic condition where there is PDA, or there is a something like a truncal wall regurgitation. You could also find it in large collateral. Sometimes you could get it in hyperkinetic pulses also, which is like pregnancy thyrotoxicosis. You could get a feeling of collapsing pulse with normal volume in MR and VSD. We already discussed. Generally, it's not collapsing, but it is a high volume pulse and not a collapsing pulse. Now, how do we do this collapsing pulse? Here, I think I should thank Sudhakar. You can all see Sudhakar here, and he's demonstrating a collapsing pulse. So I'm going to put the volume. Yeah, I'm going to play it. 1 second. So Sudhakar has taken all the trouble, and and it's a very recent video. You can see both him and the person demonstrating actually using the mask. Yeah. So the first thing what he's saying is it's a high volume pulse. So you check in the radial area, which is high volume, and you also confirm with the blood pressure apparatus. That's what is very important. Yes. Then what do we do next? Disappear. Now see, what are you trying to do? I mean, Sudhakar has demonstrated this extremely well. So what we are trying to do here is we are making it more and more tough for us to find out collapsing pulse. Again, let me come back and tell you, this is not the only mechanism, but this is the way me and Sudhakar and many of us do. But the most important point is once we do it, we don't have doubt that it is collapsing. If it is just a change of volume from resting to pulling it up, then you're always in doubt. Is it there? Is it not there? The method which we are describing, and which is obviously described in the books also, once you get it, you are not in doubt. So what we do, we feel the radial pulse, which is the most prominent pulse, go to the mid arm. Okay, so now if you realize we have gone to the arm till the radial pulse disappears. After that, what do we do? See, radial pulse disappeared at the tip of the finger, which is a sensitive area. We take this area, thenar eminence, which is less sensitive, and you put it on ulnar artery. So you've gone till the radial is disappeared, and after that you actually put it on ulnar artery, not radial, ulnar. So after the radial disappears, when you put it on ulnar artery and the patient is in resting position, you're not getting any pulse at all. And then see he has shown the way. You can't pull with the same hand. You take one more hand and pull it up, and then all you have to do is find out the pulse at this. Correct. Now, very important, raising is not by the same hand, because if you do that, you're going to compress the hand and you might get raising is with the other hand. You could do it at this, preferably it is done at the elbow. Raising is done by the other hand. Feeling is done by this hand at the thenar eminence. So thank you, Sudhakar, for that wonderful demonstration. Anyway, I'll be sharing the video and you all can thank Sudhakar separately. Now that is a collapsing pulse. Now let me come back to the mechanism of collapsing pulse, because this is something which people are going to ask you. The question is, why do you need collapsing pulse and what happens in collapsing pulse? Now there are 2-3 things. One, we showed the way to demonstrate. So feel the radial pulse, go till it disappears. Use the less sensitive part, put it on a difficult artery, which is ulnar artery. Use one more hand to raise. And if you feel the pulse, that means it must be really strong enough. That means it is a collapsing pulse. That is the fine. Now, why do you get it? And why do you need to do all this? One, obviously, it's a forceful pulse. The second important thing is when you keep the hand straight, you are actually putting in line with the heart, and in diastole, it drains off. And the strong systolic force is the one which is actually going to, the pressure wave gets transmitted much easily and you get that brisk stuff. So it is important to have a stronger pulse. It's also important to have a relatively empty hand which is positioned at this position. That's why you get a collapsing pulse, and it's not in doubt. Once you get it, it's much easier to do. Now let's talk about the one more pulse called the bisference pulse. So importance of bisference is that there are 2 peaks, but both in systole. What would be the best artery to feel? It's a little controversial, but believe me, you could say brachial as the answer. It's also found in femoral, but it's very well seen even in carotid, although the books have little controversy here. Personally, I would feel carotid for bisference because the character of this pulse is best felt in bisference. So as you keep, again, you can't press your, this is something which we have been discussing in multiple class. Your palpation and your, this one is a multi-step process. It's not a single step process. So it's very important for you to understand to do a multi-step. That means go a little slow. Keep it here and then slightly increase the pressure. As you slightly increase the pressure, you will realize that you're actually getting 2 taps in each this. That's called the bisference pulse. So that means you're looking at you are actually feeling both a percussion wave and tidal wave very well. That is bisference. Now, what are the condition? You would get it in severe AR. You could get it in severe AR with moderate or mild AS. AS is never severe. You also get in HCM. So the next question, which obviously your examiner will ask is, can you distinguish the different bisference pulses? Obviously, AR and ASAR is same, and the figure A is a normal pulse. B is a typical bisference, which is seen in you could see both, and it's seen more in AR. AR has to be dominant, whereas in HOCM, since the initial force is much longer, the second force actually comes because of the obstruction. It's not HCM, it can only be HOCM. There has to be obstruction. The second one is lesser than the first. The percussion wave is very good. The tidal wave is suppressed, whereas in AR, you get both the waves equal. What is the mechanism? It's augmentation of the normal pulse because there is so much volume and so much pressure. So the blood goes to aorta, it expands it beyond its capacity. So the pressure wave is formed. that much blood is not flowing. There is still some blood, so there is a collapse. Now the blood comes again. I mean, it's already there. So the initial, it's almost like a Bernoulli's phenomena. The initial force is the one which actually pushes it away. There is a slight recoil and again push. And by the time, as we discussed, the reflected wave also comes and joins here. Reflected wave itself is augmented in such condition, and that's why it leads to this kind of phenomena. Now, what is a double beating pulse? Now, there are lots of double beating pulse. One is pulses whisperance, which we discussed, which occurs in AR, ASAR, but AR more, or HOCM, or you can also get it in dicrotic pulse. Now, whisperance is something which we already discussed and all of you are aware. Let's also discuss pulses dicroticus. Dicrotic is where you get one in systole, one in diastole. Which condition do you get? You get it whenever there is decreased peripheral resistance or whenever there is hypovolemia. So what happens in these conditions when the cardiac output stroke volume is low? The reflected wave, actually there is a mismatch between a reflected wave and the forward wave. The forward wave will still produce the usual pulse. The reflected wave, which is slightly weaker, will fall beyond dicrotic notch, and you get it. So this occurs when there is a decreased peripheral resistance and decreased stroke volume. So it's more like a mismatch, and the worry is even beta blocker could produce some of this mismatch, and that would alter the hemodynamics in AS. Now, what is pulses alterance? I'm sure all of you know. Important point in pulses alterance is rhythm is normal. Okay, with normal rhythm means no change in the gap. One is a strong beat, other is a weak beat. Occurs in LV failure. It could be triggered by a VPC. VPC is not the cause, it could be triggered. It's very common whenever we do DCM angio, we do see it, and Frank Starling force is the reason. But this brings to one more point which your examiner is likely to ask: which are the pulse which you will diagnose using BP apparatus? Or what is the role of BP apparatus when you are doing a pulse? So one role is to look at the volume that we already discussed. The second role is actually in pulses alterance. So remember here, the diastole of these pulses is almost same. The diastole is same, but the strong beat has a higher systolic and the weak beat has a lower systolic. So imagine the BP here is 140 and BP here is 120. So when you come to 140, you see half of the heart rate. So if the heart rate is 100, you get tuck, gap, tuck. So half of 100. And when you reach 120, you suddenly see doubling of the heartbeat. So pulses alterance is characterized by doubling of the heartbeat, can or must be confirmed with the BP apparatus. So I hope all of you followed this. So the upper part is the stronger beats have higher systolic BP. So at certain BP, say 140, you get 50% of the heart rate. When you slowly come down, when you come to 120 or whatever is the systolic BP of the lower pulse, you see the doubling of the heartbeat. So that's what you see in the lower beat. So doubling. Okay, this is how. Now, what is the differential? Bigeminy. Bigeminy is the differential. It's all almost, as far as BP apparatus is concerned, it's almost the same. There is a pulse which is doubling of the dot Lokesh I will register. So imagine there is a strong beat and there is a weak beat. The strong beat will have higher systolic BP. Let's assume it is 140. So when you bring your BP apparatus from say 180 to 140, you'll see tuck, gap, tuck. So you are actually hearing 50% of the heart rate. You know pulse is 100, so you're only hearing 50 sounds in a minute. But when you come to 120, you're going to hear this and you're also going to hear this. So suddenly at one point the heart rate doubles. From 50, now you're hearing both strong and lower beat. So from 50, it doubles. So you see a doubling of the heartbeat. But the key is rhythm is same. You know, the gap between the beats is same in alterance. Whereas when you are looking at a bigeminy, again there is a strong pulse, again there is a weak pulse, but they are coupled. There is a strong pulse, weak pulse, strong pulse, weak pulse. They are coupled. There is a difference. But again, if you use the BP apparatus, at first you only get the systolic count of the strong beat, and then you get the count of the weak beat. So Dr. Lokesh, I hope you followed that. So it's basically using a BP apparatus demonstrating pulse. So alterance and bigeminy and pulse volume. These three are important. So dicrotic versus bisference. Dicrotic pulse, one is in systole, one in diastole. So you will not feel that it is a pulse, but you feel a slight movement. Most of the time, it's not a different pulse. So it's just a slight movement. It's very well appreciated in the monitors. But even when you feel, you will appreciate a slight movement. Whereas bisference will be in systole. It is one cardiac cycle. If you feel palpate with the apex and this, but you feel two taps. So bisference, mentally you need to differentiate from actually anacrotic pulse, which is nothing but a shudder. It's not a pulse, but it is a shudder. Okay. So pulses alterance. So pulses alterance, this is okay. Let's not go into that. Bigeminy is one. See here also, this is how it looks. 2 beats, one strong, 1 weak, one strong, 1 weak. But the problem here is the rhythm is not regular. It's regularly irregular, whereas alterance will have rhythm regularly. So this is how you distinguish alterance and from bigeminy. Any bigeminy, whether it's an atrial bigeminy, junctional bigeminy or ventricular bigeminy, will have these features. Now, one more important pulse, which is a pulse, again needs a BP apparatus to confirm. That's called pulses paradoxus. And all of you know, nothing paradoxical. It is exaggerated inspiratory, exaggerated inspiratory fall, because inspiration lungs expand, so the left-sided output decreases. Expiration lungs are squeezed, and the left-sided, no, you're not talking about right heart, you're talking about left heart, decreases. So that's why exaggerated inspiratory fall in BP. So again, how do we pick it up? We do it with, we do it again with the BP apparatus. So initially you get, only heart rate only during expiration. Okay. Initially you get tuck, tuck, gap, tuck, tuck. And when you come down, slowly, you should not ask the patient to take a deep breath. Normal breathing, very slow decrease of BP apparatus. Most of you may not have that kind of patience to do it, because generally, how do we take BP? We go to 130 and we come, straight to 80. That's what is done most of the time. These pulses cannot be picked like that. You need a BP apparatus. So when you do that, you get tuck, tuck, gap. Unlike the alterance. Alterance was tuck, gap, tuck. Whereas here it is 2 beats, tuck, tuck, gap, then tuck, tuck. And as you come down, say at 140, you get at 124, you are able to hear both inspiratory and expiratory, and the heart rate will now start become tuck, 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 tuck. When I talk about heart rate, it's the coruscant sound which you are hearing through your stretch to the arm. So that's what it happens. Here there is no doubling, but you get both inspiratory and expiratory systolic BP or coruscant sound, whereas there you only get during the expiration, not inspiration. This is found in tamponade. That's the traditional example, but there are at least 10 other causes for pulses paradox. I'm sure that's not the point of discussion. Most of you know it, so we could do it. If not, I'll pass on this and you could do that. Now, mechanism we already discussed. It means ventricular interdependence to some extent, whatever reason. And in CCP, we already discussed it is more about failure of transmission of the pressure. Where do you get reverse pulses paradox? This is something which people like. Again, they will ask you in exam. So you have to get an inspiratory rise in BP. HOCM is one condition which is exactly opposite of all others. It behaves ulta. So obviously inspiratory rise. If the patient is on a ventilator, it makes sense. Now inspiration is actually pumping out the blood from the lungs, so it is more. AV dissociation also it gets. So Dr. Anuradha is how to measure pulses or it is. Please explain again. Yes, I will. Pulses paradox, not alterance. Okay, so let's go to that picture of pulses paradox. So initially you're only getting expiratory heart sounds, coruscant sounds. Why? Because the expiratory BP is higher. So imagine expiratory BP is 130. And one expiration typically has 1 or 2 or 3 heartbeats, because breathing is only 16 to 20, heart rate is 80. So typically 2 or 3 heart rates. So imagine the patient is breathing out, not forcefully, normally. So you get the BP is 130, you get tuck, tuck. Patient takes a breath, the inspiratory BP is not audible. Why? Because it is below that sound. Okay. Again, patient breathes out, you get tuck tuck. Now the patient is, you are slowly decreasing the corosco, deflating the apparatus, and when you come to say 130, from 140 you come to 130, now you're going to get tuck tuck, and also the inspiratory BP also is heard, so you get tuck 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 tuck. So no doubling, but you feel all the sound, you don't get that pause which was there. So at a higher BP you're only getting expiration, and at a lower BP you get inspiration, you get it in all of them. Okay, that's how you get. Alterance is doubling of corosco sounds. When I say heartbeat, remember it is corosco sound. Dr. Prithvi has a question. Can you explain the mechanism in airflow obstruction? Airflow obstruction, it's a little simple in the sense the inspiration actually becomes much more, so the pleura becomes more negative, so obviously there is exaggerated inspiratory response. Normal breathing, the pleura is negative, but imagine there is an air hunger, you breathe little more, so the systolic BP falls much more. Sudhakar has a question. Can you explain the difference between paradoxes in constrictive pericardial respiratory disease as most important for their exam? Yes. So paradoxes in tamponade is very, very more, it's much more demonstrated. In respiratory disease, as we discussed, it is, you realize that patient is actually breathing much faster, and you also realize that there is exaggerated normal, that is around 20 to 30 millimeter at most. But in tamponade, it's possible for completely disappearance of the pulse, it's much more, and the respiratory rate doesn't vary much at all. What happens when we check BP in bigeminous? Bigeminous will be exactly like alterance, because there is a strong beat, there is a weak beat, but the problem is the consistency. You see that in alterance, the heart rate is same, so the beat, the gap is tuck, 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 tuck. Whereas here it will be bigeminal, it will be tuck, tuck, pause, tuck, tuck, because there is a compensatory pause there, which is incomplete. So bigeminous, the rhythm is not okay, whereas alterance rhythm is okay. The definition of alterance is sudden doubling of the heart rate with normal rhythm. If it is abnormal rhythm, it is bigeminous. So I think we have discussed reverse. Yeah, vessel wall. That's the next point which we need, which we keep talking about, vessel wall formation. So is it important? If you ask me, not important at all. Why? Because people have always thought we are looking at atherosclerosis. Okay, it's definitely not true, because the radial artery is resistant to atherosclerosis. If at all there are two arteries which are very, very, very less atherosclerosis, one is lima or rima, internal mammary, or now we call it internal thoracic artery, ITA arteries. Second is radial artery. For whatever reason, one belief is they don't have vasovasorum and hence atherosclerosis is less, but that is subject to debate. But the thing is, radial artery is not that prone for atherosclerosis. So your explanation of the vessel wall does not help at all. If at all, you're only looking at arteriosclerosis, and there is no relationship between, direct relationship between arteriosclerosis and atherosclerosis. But it's been a tradition, younger people, you can feel the artery very, you can feel it very soft. In older people, it's little cord-like. So vessel wall character in defining atherosclerosis is not much, but you have to do it in the exam. But it's really not important. But if you have a brittler artery, the pulse looks more rapid and more brittle, and some of you are finding, like pseudo, you can get features like pseudo hypertension, you may be able to difficult to obliterate, and some of, even with severe AS, you might feel the pulse is very, very jerky, and these kind of things you could always get because of hard vessel wall, but not really atherosclerosis. Apico pulse deficit is extremely important, as we discussed. More than 10 with a reasonable heart rate is sign of AF. And how do we do that? If you're one person, you're supposed to both keep the step and feel the pulse and only count the miss beat. If you're one person, if there are two people, you measure simultaneously and minus. This could also occur that at 10K, actually to distinguish between the ectopic when they're infrequent. But if you have a very frequent ectopic, they can also produce apicopulse deficit, which is more. So more than 10 is not pathognomonic, but very suggestive of atrial fibrillation. So what is actually apicopulse deficit? They are the BP which have not reached diastolic BP. Imagine, in AF each there is a beat to beat variation in the systolic blood pressure. Diastolic blood pressure is almost same. So in AF you're made to check each BP 3 times. Why? Because the systolic BP varies. But diastolic doesn't change much, because diastolic BP is decided by the peripheral resistance. So whatever is below the diastolic BP actually becomes a missed beat. That means whatever is below that doesn't come out, but you can hear it in the chest, but you don't get it in the heart rate. So this is what is apex pulse deficit, but could occur in a very nearly occurring ectopic also. It's not pathognomonic of AF. So these are the features, typically less than 10 in VPCs, but not in bigeminy. Non-bigeminy VPCs more than 10. A wave is present if it is VPC, but absent if it is AF. Exercise, physiological ectopics disappear, but VPC it persists. Pauses could be seen, whereas here it is completely irregular. Either partially compensatory pause is seen after VPC and a full compensation, whereas here it is completely irregular. Okay, the other point also is very important. It's probably the last point I'm going to discuss, and that is the delay between the arteries. Please note this and please by heart these numbers, because your examiner is going to ask. Also remember, as a human, what delay can we appreciate? The answer is 30 milliseconds. Whether it is heart sound, whether it is palpable, whether it is delay. If somebody asks, as a human, what is your capacity to distinguish delay? The answer is 30 milliseconds. 30 milliseconds is what you can pick up. Less than 30 you can't pick up. What is the time taken for the pulse to reach? We already decided it's 5 meters per second. So you have to find out how fast, what is the distance between each of these structures. So from apex to carotid, it typically takes 30 milliseconds. If it is more than 30, we call it apicocarotid delay, and that is the sign of LVOT, left ventricular outflow. Not seen in HOCM because the initial jerk is seen, but all other HOCM you get, all others you get apicocarotid delay. The brachial is 60, radial is 80, femoral is 75. Okay, so typically when you take radiofemoral delay, ideally femoral comes, because it's a direct continuation, comes before radial. So whenever there is a radiofemoral delay, you actually pick up. So simultaneously you have to palpate, and you realize that your femoral, which was supposed to come before radial, now comes after radial. You'll be able to pick up only if there is more than 30 millisecond delay. Anything less than that is not, unless you're a superhuman or a flash among you all. Typical humans cannot pick up this difference. Causes is any obstruction there, could be atherosclerosis, but typically it is cocked, can also be seen in Takayasu. Radial delays, again, you know that you could also see pre-subclavian cocked can produce radial delay, anomalous can produce radial delay. Again, Takayasu aneurysms can cause radial delay, and also supravalvular AS can produce a brisky, little faster right carotid than left carotid because of the jet in that direction. Very important, which I told you in the beginning, but it is very important for you to understand that all pulses you know how to examine. Surgical book Das is one which gives a best explanation. You may be asked to demonstrate. So whether it's brachial, whether it's carotid, whether it's dorsalis pedis, whether it's popliteal, whether it is femoral, please make sure that you know how to do it. And if the examiner is asking, you should be able to explain it. I won't go into that. Okay, carotid pulsation JVP we already discussed, but this is just for completion. If you are having this slide, please go through it. So thank you for patiently listening to me. There are 2-3 Sanjana has asked the question whether 2 people are checking, then 2 people separately check apexocarotid delay, but if it is 1 person, then it is easy. if it is 1%, it's only this. Auscultatory gap is what you get in blood pressure, where there is a systolic, unless you do a palpatory method, you will miss. And believe me, when we were in our training, it was common thing. Our boss was very particular about BP, and some of us ended actually missing because of auscultatory gap. Always make a habit. So it's become a habit for me to actually look at the palpatory method as I'm inflating the pulse. Make sure that you're above systolic and then get this. The mechanism is not that clear. The sound just doesn't appear at that time, and that's how you get. Dr. Sumit has a question about different pulses, differentiate between different pulse, bisference pulse. Yeah, bisference is 2 pulse in systole. So it is 1 beat, but you're getting 2 proper pulses. That is bisference. That's the only differential is probably anacrotic pulse, which the shudder might confuse you. The dicrotic pulse, the second one is not really a pulse. It's just like something is just pushing it up, but it's not really a pulse. So it's not that common. So one thing I want to, the reason, it's not the reason, I think Dr. Govindraj is asking why 10 a cutoff. 10 is not a full cutoff. Please understand, it's found that if it is AF, you're going to have multiple beats at multiple random interval. So if your heart rate is around 80 to 100, you could have 10 beats which are actually below systolic. It makes the chance more likely. 15 is very ideal. More than 15, it's almost surely AF. But 10 is the cutoff which is kept. So somebody wants to know about reverse pulse paradox. Yes, reverse pulse paradox occur in any condition where inspiratory BP is higher than expiratory BP. Because pulses paradox, you have expiratory BP higher, which is normal also. It is exaggerated. So which are the condition where inspiratory BP is higher? So that could become higher, say in ventilator. If there is ventilator, instead of thoracic pressure becoming negative during inspiration, will become positive. So if you're putting a ventilator, the blood could come up and there is more beat. The second thing what could actually happen is in HOCM. Why? The emptier the heart, there is less obstruction, and there is more obstruction, and fuller the heart, there is less obstruction. So if you see in and once the obstruction is less, the BP will be higher. So that is why HOCM behaves opposite of other condition. So although the inspiration, the heart becomes empty, in expiration, the heart is actually empty, but the obstruction becomes much more. Inspiration, the heart is, the fuller the heart, the obstruction is lesser. So it behaves exactly opposite of other condition. Now, third cause is actually AV dysynchrony, but that's not really because of the inspiration expiration. AV dysynchrony, whichever beat has AV synchrony, the BP will be higher. Whichever beat has no AV synchrony, the BP will be lower, because 30% of contribution is from atria. So that is variable, and it might give you an idea that the BP is actually rising during inspiration. So that's how it is. Water hammer pulse mechanism again, yes, it's the empty chamber. If you raise it now, the arm is in direct country with the heart. So empty vessel now, the force of the pulse, because it's in straight line, the pulse wave actually transmits much easily, and you feel the pulse. So when you raise it up, you feel that, because it is in straight line, you get a beautiful direct feeling. Collapsing pulse video, yes, we should. It's Sudhakar's video. I'm sure he'll share it with all of you. One more thing, what I want to discuss apart from what I discussed is hill sign. Hill sign is actually a problem of a pulse. And what is it? So if you understand hill sign, is it a real sign? Hill sign occurs in AR or any aortic, wherever there is runoff. Is it a real sign? No. If you put a catheter in femoral and catheter in radial, the BP will be almost the same. So it's not a real sign. So why does it occur? Because now the aorta, the femoral arteries are a direct continuation of aorta. So since they are direct continuation, if you occlude it, the reflected wave comes immediately because you occluded it. Generally, reflected wave reaches till capillary and comes back. So when you occlude it, the reflected wave comes immediately. Higher is the, more is the volume in iota initially, more will be the reflected wave. Hence, it is proportional to the severity of AR. So this is how you get. So the mechanism of Hill sign is actually the reflected wave. That's one sign because radial artery is the half branch of aorta. So the contribution of reflected wave is not too much in radial artery, whereas contribution of reflected wave in the occluded branch of aorta, direct branch of aorta, is higher. That's why you get Hill sign in AR. So that is one more thing. Although it's a Hill sign, it is it's from the it's to be understood when you understand pulse. So Sudhakar, are we done or any?
Yeah, I think we are done, sir. Yeah, I think we have answered all questions, sir.
Yes. Anything you want to share?
No, I think so after I think it's all done.
Yeah, but if there is something, please share with everybody. Yes.
I just want, sir, this radiofemoral delay. I think just one important thing I just want, like when we see radiofemoral delay, I think it's the time of onset of. It's not the time of like radiofemoral delay. It's the onset, like the delay of onset of the femoral pulse. Like which is more important, I think, like not the time of from the radial to femoral delay, but is it the time of like delay onset of the femoral, which is more important.
Typically in this condition, the femoral is delayed and the radial is normal, but the way to demonstrate is look for radial and femoral simultaneously.
Yes,
normally you expect them to come simultaneously, and theoretically radial should have been after femoral, theoretically.
Yes,
75
sir.
and 85, but
Yes,
that
sir.
you can't appreciate
Correct,
normally.
sir.
So
Yes,
here radial comes and there is at least 30 millisecond gap, and then the femoral comes.
Yes, sir.
So that's what, but it's not the time from iota, it's the time between these two which makes it this.
Okay,
But
sir.
any clock, this is one finding which is easily demonstrable, Sudhakar. One is epochocorrected delay, which can be easily demonstrated,
Correct.
and radiofemoral in a cock can be easily demonstrated.
Sir, one more question which like many people ask is in patient with AS and AR, like severe AR and mild to moderate AS, what is the mechanism of bispherians?
Yeah, the mechanism of bispherians is same as mechanism of AR, because now there is too much blood, and
Yes.
when the blood peaks, imagine there is a mild or moderate AS, that's
Yes.
going to give that extra jet. And
Okay,
this
sir.
extra jet, which is almost like a Bernoulli's principle, that extra jet, it hits the aorta and it diverts it too much. So actually presence of a mild or moderate AS accelerates that just still further and makes bispherians really possible. If you have a mild AS or a moderate AS, you almost always have bispherians in AR, because even without that, AR can do it. A huge blood coming into aorta can do it. But if you have AS, the force of the jet actually increases several fold and bispherians gets exaggerated.
And you can never have a bispherians with an altered LV function, sir.
Yes, that's one very important point, because I think I missed that point, Sudhakar. Thank you for reminding that. That's a point which we need to highlight here, that moment you utter bispherians at MD or DM level, you cannot tell LV dysfunction, because look at the mechanism. That initial percussion wave need to have a force that can only happen if LV is normal. So if you have bispherians, you are committed to a normal LV function. Thank you, Sudhakar. I had missed that while telling. That's a very important point. The bispherians should have normal LV function. Yes. And AS is never severe. That's one more point.
Yeah, correct, sir. AS is never severe.
Yes.
Yes, sir. I think that's more. Yes, sir. Here we'll conclude, sir.
Yes, I think Shantanu can conclude.
Mr. Shantanu, sir. Yes, sir.
Yes, sir. Thank you, sir. We are now towards concluding this wonderful program. I must say this was an exciting program which has enabled us to gain from the wisdom and expertise of the speaker and panelist. I take this opportunity to thank Professor Dr. Ranjan Shetty and Dr. Sudhakar Rao for their great contribution in making this program possible and successful. I am thankful to all participants who have taken time out of their busy schedules to attend this program. I thank all of you for making this event success, and I sincerely hope your support will remain with Torrent in times to come. Thank you, goodbye, and good night to all, sir.
Yeah.
Thank you.
Thank you. Bye. Bye. Bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Yeah.
Hello. Hello.
Yes, sir.
Hello, sir. Can we get the video and PPT of sir's presentation? Is it possible?
I will share the video link. If you can just drop the mail ID.
Okay, just a second, sir. I will drop the mail ID.
You can put it on the chat box. I will share you the link.
Okay, sir. Sure, sir. Sure.
Okay, got it. I will share by the evening.
Thank you, sir. Thank you very much.
Sure.
Rahul? Rahul? Hello?
Hello.
Yeah, tell me.
I wanted JVP topic also. Is it possible? I have sent my.
Yes, if you can just drop me the email ID, I will send you the.
I have dropped the email.
What is your email ID? If you can just help me.
brashp@yahoo.co.in.
Can you say it again?
Oh yeah, just now I have sent. I think last, but. Sorry. Just hold on, please. Can you please check? It's in the last but one. Brashp.
If you can just mention, or else I will just drop my number.
Yeah.
You can just put me a message.
Please note down. Is it possible to note down? I will just.
Yeah, I will write it. Tell me.
Brash, B-double-E.
B-double-E.
B.
Yeah, B-double-E.
R-E-S-A.
Okay.
P.
Okay.
At yahoo.co.in.
Okay, fine. I'll send you.
I will return your number also. Thank you so much.
Thank you.
Okay. Nice of you.
Okay, I'm going to close.
Yes, sir.